All right, folks, welcome back to week number 3. So you should all be comfortable by now with saying silly things and asking strange questions. I'm very excited about today's talk. We have 2 guests with us. So Dr. Won Choi is a member of the Department of Pediatrics at Michigan Medicine. Her work in hematology oncology is focused on the outcomes of HCT.
Bone marrow transplant. Another.
Thank you. It was the hematology. Yeah.
Bone marrow transplant.
Bone marrow transplant and its effects on biological, clinical, and psychosocial outcomes in patients. And then we'll also have Dr. Jodyn Platt, who is an associate professor of learning health sciences here at UM, trained in medical sociology and health policy. She's interested in understanding what makes data-driven health trustworthy and the pathways for earning, achieving, and sustaining trust across stakeholders. So kind of a nice little bridge with the privacy issues from last week. We didn't plan it that way, but we're going to pretend we did. And so the same drill, we're going to ask them to speak for a little while to give us some context and then start asking lots of really good questions and giving lots of really good ideas. All right.
Thank you. So it's a real pleasure to be here this afternoon. And thank you, Dr. Cohn, for inviting Jody and I. So Jody and I have known each other for a long time, and we have collaborated on this topic. And that's amazing that, Amy, you picked this up and invited us to actually talk about this because we've done some research on this. So it's a pleasure to be here. I did make a few slides because it's actually quite complex to talk about bone marrow transplant. So put yourself in the seat of a patient hearing this for the first time. And this is essentially what I'm doing in a consult for the first time. And so I thought it would actually be nice to have some slides, but please interrupt me at any point. It's not meant to be technical at all. I really want to get to a level where you guys can understand it and we can talk about the issues related to privacy and security and really understanding what the patients and families are consenting to. So as Dr. Cohn mentioned, I am a pediatric oncologist. So I take care of patients who have cancers as well as non-cancers of the blood. And one of the therapies that we can use to treat cancer or other blood diseases is something called bone marrow transplant. So the first few slides is just giving you some background about this relatively complex procedure. Okay, so
you can just click on the screen, yeah.
Perfect. Okay, just to give you a little bit of history of transplant. So in the early 1900s is when the blood system, the ABO, the type of blood that we have was actually discovered. And it was not until a half a century later that something called the HLA genes were first described. And this is where the first transplant from 2 twins were done, meaning into sibling A into sibling B who were genetically identical. 1968 is when a non-twin was done for this disease called SCIDS. So this is one of the most famous diseases you've probably seen on TV, where it's like the bubble boy, right? So they were in a bubble so they don't die from life-threatening infection. And the only way to treat this underlying condition was through a bone marrow transplant. So this was performed at the University of Minnesota. And now going to 1979, in Seattle, they did the first unrelated donor transplant. And I'm gonna get to what related, unrelated, and these different terminologies. In the 80s is when, just like there's the Red Cross where you can donate blood, there's something called the National Marrow Donor Program where people can actually sign up to become bone marrow donors. And then in 2018, over 11 million people have been enlisted. Okay, so that's just a little history of transplant. This is just a slide just to show that the number of transplants we're doing worldwide, this is in the US, continues to go up. So this is no longer an experimental therapy, but really when we know of certain diseases, we go straight to it instead of offering it as a last resort as it was traditionally, because of how at certain times it could be considered really life-threatening. So there's two types of transplants that are done. So there's something called an allo transplant, allogeneic, and auto. So just as the terms refer to, auto is doing a transplant using your own cells. So we harvest those cells at a certain time point and we save it and give it back after the patient receives super high doses of chemotherapy. And then there's another form called allogeneic, and that is using a donor other than yourself. Could be a related donor, it could be an unrelated donor. And that is, I put these here just to show you that we as the clinical team sort of provide recommendations on what type of transplant depending on your underlying disease. So if you have a blood cancer like the ones listed there or anything affecting the blood, as you can imagine, you don't want to use your own cells. That's when you do an allogeneic transplant. When you have cancers that involve solid organs like lymphomas or tumors involving the bone, then we would use something called your own cells, the auto transplant.
Before you, can you go back one
Yes.
just for a second?
Yes.
Anybody else have the question that I'm dying to ask?
Yes.
Go for it.
Why did it go up and then it went down and it went up again? Allogeneic transplant.
So, oh, that is such a great question. So in the 90s, there was a big explosion of doing the auto transplants for breast cancer. And we quickly learned after a number of years that it was actually not beneficial to do auto transplants for breast cancer. So the numbers dipped, and that was the big sort of explosion related to the number of transplants we did for breast cancer. Great question.
Thank you. It was gonna bug me the whole talk,
Yeah,
so.
so that is such a great pickup on that. Okay, so this is just a slide just to show, this is actually when we do a consult with families, we have to walk them through understanding what is a transplant and how do we get these cells. So when it's an auto transplant, the patient actually historically, they would be going to the operating room and we would basically get it by doing a needle that goes into the hip bone and just harvesting it. But now these days, I don't think I left the slide in here. We actually do we call it harvesting through the vein, and we can actually do it that way. And allogeneic transplants, we prefer to go to the OR to get it to the bone marrow. But due to the ease and just all the sort of logistical purposes, more transplants are done by taking it from the vein. But studies have shown that there's different risks between using a transplant and doing it from the vein versus the cells that we obtain from the bone marrow harvest. And this may come up, I think, on the next slide, where I have this quote that one of my colleagues gave. When you have two options that give equal outcomes, choose one that gives less toxicity. Maybe, not always. So I gave you a perfect example of how we actually get cells from a donor. We can either get it quite easily from just a vein where you're hooked up to a machine, it basically pulls it out, an apheresis machine. Or we have to take the donor to the operating room. They have to get anesthetized. They undergo about a 1 to 2 hour procedure for us to take a needle and harvest it. So yes, equal outcomes, meaning we get the donor cells, but there's different types of toxicities that are associated with one type of cell versus the other. And that, oh, did I end there? Is it not an infant? Okay, so that's this complication known as graft versus host disease. This only occurs in the allogeneic when it's a donor other than yourself. And basically, we have now taken the donor cells. We're going to put it into the patient to help rid the cancer or the other sort of diseased blood cells. But sometimes up to 50% of the time, we could cure the cancer with these new donor cells, but we could also introduce a new complication, and that's called graft versus host disease. So sometimes we can cure the cancer, but then there's these other toxicities that we could introduce, not even going into other discussions related to the profound immunosuppression, where we're suppressing the immune system to allow this new donor cell to take. So we have to speak with our patients and families about the risks associated with the transplant, and this is one of the biggest risks. There have been a lot of advances over the last 50 years, including taking the cells from the vein as opposed to going to the marrow. But I alluded to some of the sort of toxicities that we can get from doing this more simple approach of taking it from the vein. We've learned that doing transplants from cells that are harvested from the vein as opposed to directly from the hip could possibly increase the risk for graft versus host disease based on the type of cells that are taken from the vein versus the bone marrow. And so we talked to the patients about that complication, about infections, other organ toxicities. And so there's a number of things. Imagine in a 1 hour consult, you're trying not to overwhelm the patients and family, but you want to cover all of these aspects. But for them, they just hear, oh, bone marrow transplant, you're going to cure my cancer. But we also have to talk about all these other complications that could potentially come with this type of therapy. And so the point of this slide is just all the different things that we need to cover in a consult and for them to hear during that 1 hour. The life-threatening complications, meaning, yes, we do the transplant, but there is still the possibility that your cancer could come back. We do the transplant, but we could give you another complication called graft versus host disease. And then it could also, as a result, lead to these other complications. And so it's important during this hour to have a very balanced and try and provide as much data that we can to patients without overwhelming them with scientific jargon. So maybe with that, yes.
Do you get graft versus host from your own blood, or is that?
Great question. And I think I did skip that. So the answer is no, because it is your own blood cells. So if I think people understand A, B, and O, the reason why when you get a transfusion, you need to get a matched transfusion, right? So what happens with a allogeneic when it's not yours, we do the best we can with the typing, but it's really still genetically not you. And so it causes this reaction of the donor cells essentially attacking your host cells. So great question. Yes.
For the autologous transplant, since you're collecting like that patient's own cells,
Mhm.
how is that a good thing to put back in their body if you're collecting it prior to the cancer or like
So-
while they still are having the cancer diagnosis?
Yes, so that's a great question. And that's why it's very important to really understand the indications for which we do the transplant. So I alluded to how transplants, when you're using another donor, we usually reserve for those involving the blood, right? Because an auto transplant, if your blood has any diseases already in it, you don't want to use the same. So the auto transplants, we generally reserve for cancers that involved sort of solid tumors, not in the blood system. There are certain cancers that start off as a solid tumor, but can then invade the blood. And so what we do is generally check the bone marrow to make sure it's not there or that we've cleared it before we harvest. But that is a really good question, and we sometimes have to do a bone marrow test to make sure that we've taken and gotten rid of all the cancer before we harvest and also before we put back in. Yeah, so those are all really great questions and ones, you know, generally when we're doing a consult, and I'm sure Jody's going to get into this, we already kind of know if you're going to get an auto versus an allo. So we don't have to overwhelm them too much with, okay, there's this type of transplant and there's this type of transplant. But as you can imagine with the allogeneic transplant, there's far greater risks. And so we spend a lot more time. And there's a lot of other nuances that I didn't get into. And it goes back to your question of auto versus allo, is there graft versus host disease? So we have learned a lot in the science of what are sort of predictors of graft versus host disease. And a big one is how well matched you and your donor are. So we spend a lot of time talking about if we know the type of donor they have, which will help us guide our discussion in terms of risk for developing graft versus host disease, depending on your donor type.
Sorry. Is donor type more than just blood type? Are there like other factors that come into it?
It's your, it's called tissue typing. So for example, if you have a heart transplant or a liver transplant, there's other typing than just the blood that we have to be matched for to help prevent the graft versus host disease, or in terms of solid organ transplant rejection. So there are other things that we actually type for. It is a blood test. And when people sign up through the National Marrow Donor Program, we get their blood test to tissue type them. And when a patient is being worked up for transplant, we do both to match the donor and the recipient. Yes.
How strong are treatment guidelines in the field that help along with these decisions along the way? Like under what conditions this type of harvesting versus this type of harvesting is recommended?
Yeah, so there are pretty good guidelines published. It's by nature being in the cancer field, and it's a very sort of, I wouldn't say niche therapy, but a therapy that is associated with potentially lots of complications. There are pretty well delineated sort of rationale for treatment choice, the types of chemo we use, that folks in the field generally use standardized guidelines. But there are gray areas where we do have to consult experts in the field, where we, you know, reach out to other colleagues at different centers, depending on how rare the disease may be. But generally, there are pretty good guidelines that we all follow in terms of indications for transplant, the type of regimen that we like to use, and things like that. Yes.
Is there a genetics component to this? As in, I assume that we don't have it down to that level of the science where we can compare one genetic sequence versus another. But do you think that's is that something that's been looked into, or is that even a reasonable avenue to look at this through?
So the genetics of why one person would be at risk for developing the graft versus host disease, or is
Like
that your?
Comparing the genetics of the donor versus the person with cancer.
Oh, yeah, there are definitely researchers in the field that are trying to look at certain genes on our tissue typing that we already do to see if there's even more fine tooth genetics that we can tease out that we should be matching. When I first started in the field roughly 20 years ago, we were only doing tissue typing for 6 alleles. But now we do 10 because we're identifying these other areas on the gene that tells us if they're mismatched here, the risk for GVH is going to be higher. So we're constantly trying to research those areas of why, even though, for example, let's take blood typing because that's a little bit easier to understand. I'm an A, you're an A, should be perfect, right? So the same thing in bone marrow transplant. Oh, we're matched at 10 sites, we're perfect, and yet one set donor recipient, the recipient gets rip-roaring GVHD, but someone else who has that perfect 10 match only had no GVHD. So we're trying to understand all those factors that why one person's risk is greater than the other. Yeah.
Yeah, is the tissue type thing or the HLA compatibility a situation where being like a sibling or a family member makes it
Great
better?
question. Yes. So at our initial consult, we talk about how, okay, for a brother or sister, the ability to be a perfect match is 25%. But if the unrelated donor and the risk and we know just because there's probably more genetic synergy between the patient and the sibling that we're not testing for, we know their genetics are probably more in line than an unrelated donor. So the risk of GVHD with a sibling is much less than an unrelated donor. And so that's absolutely true. And male donors generally cause less graft versus host disease than women who've had babies because of antigens that cross the placenta and things like that. So other factors so when we're, as the physician, looking at the type of donors to choose from, those are factors that we will look at.
There's one over here.
I noticed that there's a lot of infection in terms of.
Yes. Yes. So during transplant, I didn't even get into this. In order for the new donor bone marrow to take, right? I mean, you're basically transplanting someone's whole immune system into a recipient. And in order for it to take, we need to suppress the recipient's immune system with medication in order for them to take the new bone marrow. So there's a long period where the patients are at risk for developing infections. And particularly, so our patients are often wearing masks in and outside of the hospital. So they were wearing masks long before COVID. And so many of our patients were like, we've done this for a very long time. This is nothing new for us. And so, yes, absolutely, because they're profoundly immunosuppressed.
So the way this kind of plays out in my layperson's mind is you get in a transplant to avoid graft rejection or related issues, you suppress the immune system. Okay, but what we're trying to transplant is the immune system.
Correct.
So are they continue to be on immunosuppressants, and isn't that killing the very thing they're trying to get?
So good question. We're suppressing the recipient's immune system so that the new cells can go in and grow. It invariably will affect those new cells, but they are robust and healthy, and it will take, it's like planting seeds. It takes time for them to grow, and over time, they will grow and expand, and miraculously we infuse them and they just know where to find their home and start growing.
So, if everything goes well, will the patient eventually go off immunosuppressants?
Yes, so unlike solid organ transplants, where they are on lifelong immunosuppression to prevent rejection, in bone marrow transplant, outside of developing graft versus host disease, if they do not, we generally like to have patients off immunosuppression around 6 months to a year. It takes about 6 months to a year to taper off. Great question. Yeah, so this is a lot of information that we are giving to patients and families. And then we're just giving standard information. And then we want to talk about, oh, we have this clinical trial. Oh, we have this. So it is really information bombardment that they're getting, but you want to offer them the best chances of therapies, and clinical trials are one of them. That's just one piece of what we're doing. Obviously, I keep alluding to the 1 hour consult, but it is multiple follow-up discussions that we have with families as well. But this is a lot of information. I generally don't do slides at consult, but I've often thought of doing that, but that's also seems so formal as well.
So I just want to throw out for those of you who've taken something like a 310 or a 510 and think about optimization problems. One of the things that I was certainly picking up on are these trade-offs, which is really what optimization is, right? So there's the hip versus the vein, and what are the risks of one and what are the benefits of one. And as you're thinking about that, I want you to think about this notion of multi-criteria objective functions, right? So once we get to the case that there is a donor, now we're also making decisions about who the donor should be. So that's imposing risk on the donor. And
Yes.
what does it mean to make the decision? Who makes the decision? But also, how do you even think about making the trade-off of the recipient might be better off with option A, but it puts greater risk on the donor, or donor 1 versus donor 2. This family member is a better match, but the risk for the family member. So I just want you to be, as we're trying to sort of parse this into our sort of complex systems engineering world, be thinking about the fact that those are in many cases 2 different people. And I suspect it's more than 2 different people in the sense that now you have the family members of the donor who are impacted by the decision and so on. So before Jody starts to talk about things like informed consent, what is it even that we're deciding about, and then who gets to control those decisions?
And then to throw one additional thing, right? I started off, I'm a pediatrician. And so if you do have that magical sibling, how ethical is it as a parent to say, oh, Joe's a perfect match with Jill, Joe's signing up, but does that kid have a say? And so there's ethical implications and things that we need to be advocating for the child donor. So that has come up over the years as increasing importance and giving the voice to donors. There are siblings who will report, of course I would, but when you're 3 or 4 in some cases. And so there's a whole another set of physicians who actually do the donor evaluation so that the transplant team is not involved in that as well. And so that's an important factor to consider as well. The ethical implications.
Which brings us to
Yes,
Jody.
which brings us to Jody. All right.
So, so yes, I'm here to talk a little bit about informed consent. I don't have slides, I have, my notes are on slides, so if anybody really wants them, I can share them, but, and in some ways, what I need to talk about is much less sort of technically complicated, than what we just heard from Sung, but, and that's this question of informed consent. And the, what I hope, you know, in the next 10 minutes or even by the end of today is that you sort of think about what are these, you know, what are the requirements for informed consent? What are the goals of informed consent? The process that we have for it is it's bad. Like it's bad. I can say that, right? Like
It is. Yeah.
and there's a lot of room for improvement, right? But the reasons we have it are incredibly important. And so sort of getting rid of it is not an option, right? That's not one of the alternatives we're really thinking about. But what we can think about is how can we do it better? What is it? What do we want it to, what does it represent? What should it represent? And then how do we achieve those goals? And I think all of you here can hopefully maybe solve that problem someday. So
Yeah.
And so again, so improving these models is really about sort of setting the standard and holding it to the standard of what it should be and not to what it currently is. Because we actually could probably automate a lot of what we do, but it would just sort of create the same problem except digital. So I like to think about informed consent really as a sort of symbolic kind of process. That's what it is. So it's a symbol of trust between an expert, a doctor, and a non-expert, a researcher. So doctor or researcher on the one hand, and a patient or a research subject, research person. So somebody that doesn't have the same level of expertise on the other side. And they need to have some level of trust between the two of them because they're going to be doing something that's experimental, that's uncertain, that we don't know the outcome, what the outcome is going to be. And so having that sort of symbol at the center of what we're doing is important. And ultimately, it's a documentation of that agreement. So there's a form to sign. And when I first met Sung, she's like, so there's the, you consent to treatment, so that consenting to everything that she just described really well. And then there are multiple clinical trials. And for BMT, that can be 10 clinical trials. And each consent form has 15 pages. So that's 150 pages for a parent and a child in a life-threatening sort of situation. And so again, going to the ethical question, like is that an ethical way of sort of asking people, you know, whether they want to participate in a clinical trial? And very much, particularly in contexts of life and death sort of situations, consent really gets sort of thrown into like a huge question mark, because can you really, you know, you're so vulnerable, and you really ultimately relying on the trust that you have in the doctor or the researcher in that particular context, as opposed to what the issues may be and what your underlying values are around participating in research. So, but it's the documentation of the rights and responsibilities. So it's, again, there's an important sort of formalism to it. That are, again, aimed at embodying sort of the core fundamental bioethical principles of respect for persons and autonomy, justice and fairness, and then the sort of balance of risks and benefits. And Sung talked about some of these in the context of BMT, but it can be in anything. And so figuring out what the right balance is, and that's why it's 15 pages long, because it's complicated and there are a lot of risks and a lot of benefits. So the problem of informed consent is sort of as old as it is long. And it was created very much sort of in response to a healthcare system and a research system that actually didn't have any of this, right? So we were experimenting on people without telling them, right? Performing surgeries without telling, you know, them sort of what the risks and what were they going into. And so the reasons we have it are important. So the criteria for informed consent to be truly informed is that it needs to be informed, it needs to be voluntary, and it shouldn't be coerced. So what does that really mean? What does it mean to be informed? What level of informed is sort of optimal and acceptable? What does it mean to be voluntary, particularly if you're a child, if you're an adult, if you're very sick? Most of my research at this point is less with BMT patients, but more with the public, right? And around health information and data sharing and other things that in some ways are, I mean, I talk to a lot of people and it's like, well, that's no big deal. and yet others are, maybe not, right? But it's a very different sort of proposition if you're talking to me as a healthy person, as versus somebody who's sick and vulnerable. And that can change very much over time, right? So you're talking to sibling donors who, maybe 5 years old and don't or less, right? Much less, and they can't make a decision. And then what happens, that relationship between the sibling hasn't even been born out yet, right? So it changes over time. And the same thing happens, with adults and their information. Like today I'm feeling healthy and comfortable and it doesn't matter. And then something happens in the world and suddenly, I'm being discriminated against and I feel vulnerable to the system. And that then my ideas might change. And what's my recourse? Is there one? So as we get sort of more chronic conditions in the world, we're not just talking about sort of one-time incidences, and informed consent tends to be a one-time thing for people that live lifetimes and change and adapt over time. And then the sort of issue of coercion is sort of wrapped up in voluntariness. It's like, where do we, is an informed consent, document where you're sort of clicking terms and conditions? Is that a form of coercion? Or is it sort of making something easy and accessible because that's the way, that's the expectation we have around it? So those are like some of the problems. There are a couple other things I just want to touch on before we sort of get to questions and solve. I mean, I'd love for you to solve consent. So again, what do we do with vulnerability? Vulnerability can be thought of in different ways. A lot of sort of technically, legally, we think about vulnerability as physical vulnerability, psychological, and social. So again, children are often sort of a classic vulnerable population, but even how we think about vulnerability in society changes over time. And then how does that impact, informed and voluntary consent? So again, we see in some of the research that we did together, when we talk to patients, they have very high trust in their physicians, and it's consent ends up being tied up in that relationship. If I talk to the public, my metrics of trust look much bleaker, right? People don't trust the health system. They don't necessarily trust their healthcare providers. And so it's a very different balance of how we approach people. And then there's certainly issues of equity, which I would encourage you to tell me about. I know your background's a little bit. So how would you think about equity in the form of, as it relates to this kind of process and procedure? Yeah, reading level is a huge, important issue. Yeah, and accessibility of the system, right? I don't know. Do you have to do your reading level for the clinical trials, informed consent documents? Do they get evaluated on some kind of Kincaid score?
Gosh, I don't think the IRB gives us a grade for it. They don't really. We try our best to make it language as lay as possible, but it's complicated terminology.
Right, there's so many ways. Yeah,
It's tough, and when you start listing drugs that have these really complicated names, it's hard.
I'd be interested in looking at how physician trust or healthcare system trust varies with like exposure to the healthcare system, because then you start thinking about wealthy countries with, hospitals and major hospitals in every city, and everyone has, by global standards, good access to healthcare. And then if you start looking at, poorer countries and they haven't seen a physician just literally as many times in their life, I'd be interested in seeing how that correlates with trust in the healthcare system.
Yeah, and I think, so where would you put the United States on that spectrum?
At the top.
Yeah, I mean, I think we find, I mean, in the US in particular, it's such a fragmented system and people don't necessarily have you know, a regular source of care. I mean, in the context of bone marrow transplant, you have years to establish a relationship, right? 2 years, a year.
It
Yeah.
depends on the disease.
Yeah.
For which you're getting a transplant, where, yes, if you have a prior diagnosis of a cancer, generally you've been with your oncologist first before you come to see the bone marrow transplant. But then if you have a non-cancer diagnosis and you need to rapidly go to, like I gave the example
Yeah.
of the local boy, if you have to rapidly go to transplant, there's less of a relationship. And it becomes more difficult to have these discussions with, compared with people who've been in the hospital system for a while. So there's definitely the relationship factor that with the informed consent process that is either helpful or not.
I think that people's experience with the healthcare system influences whether they trust it or not. And certainly certain populations have poor experiences. So like African Americans frequently may not have had positive experiences in a health system, which then influences the trust that you have in it.
Yeah, and that's definitely borne out in the studies that we've done. We did, so one of my colleagues who's now at the University of Minnesota did a very simple, nice sort of survey around the experience of discrimination in the healthcare system. And one of the things that she found that 1 in 5 people had ever experienced discrimination in the healthcare system. And obviously a lot of that was racial discrimination, but there are other forms of, you know, people get hassled, but it's not easy to access the healthcare system.
So building off on that a little bit. I don't know if this is a useful direction, but maybe it'll spark some thoughts for someone. I've certainly seen data about physician bias in terms of things like recommending whether or not someone is strong enough to have a particular heart surgery or something. We're talking largely about how a patient makes a decision based on consent. Is there any work on ethics of how options are presented and how that when you're offering consent, I assume that you are not, that you're frequent, maybe I'm wrong, that you're not necessarily saying this is the plan, yes or no. You're talking about like, okay, do we have, you know, a sibling donate versus this, or, you know, and to what extent is there literature about the behavior of the physician in that process varying with underlying biases?
I can't speak specifically for BMT if that research has been done, but it has been done at a hospital level in terms of how you will offer certain patients certain procedures or therapies based on your underlying diagnosis. So I imagine it extends to BMT as well. And that is why, and for good, we're doing all this bias training and things that we didn't previously learn, but thankfully we are learning all of that and getting more information and research about all these unconscious biases we as physicians hold going into our interactions with our patients and families. So specific to BMT, I'm not sure if they've done that, but certainly there is at that hospital level. Yeah, at that initial consult, there's a lot of discussion trying to educate the family about their disease and what the options for therapy are, including our recommendation of, given the data, your type of disease, your prior response or lack of response to therapy, here's our recommendation, whether it's transplant versus continued chemo or other options.
Is it a one-time decision or is there like a sequential process where it's like you may, particularly when I'm thinking about like bone marrow transplant, is it sequential at all where you might start and then decide, I want to stop this, I don't want to continue, or?
Well, so if I understand your question, once it has been decided in terms of here's our recommendation. So even though we have an initial one-on-one with the doctor and the family, at least at our practice at Michigan, and I do know it's nationwide. We go back to like our colleagues, and there's a board, like a meeting that's we present the case essentially. 8-year-old female with this X, Y, and Z. Here's the data. This is what my recommendation is. Do you guys agree? And then people will either agree or not, or bring up some controversies in the decision making. But once we go back to the family and say, this is our recommendation to proceed with transplant, and then the patient and family agree to it in terms of once we go down that path and they start the chemotherapy and we've collected the donor, no, you don't undo that process once that has been decided. But that takes several weeks to sometimes months. So you can get second opinions, or and other things could evolve over time that changes your decision. But it's not like surgery tomorrow, transplant tomorrow. It does evolve over time. But once you start the chemo and the donor's been collected, you're sort of on this path.
Jodyn, can you talk a little bit about part of what makes this so challenging is the PEDS component and the donor component. So I'm just picturing parent with two, say, teens, and it's not even just the parent versus the child debate about treatment, which I presume starts happening at a fairly young age, that there can be differences. There can be differences between the parent's desires and the donor's desire. There can be dynamics between the siblings. How does the world of ethics even view how do you define what is ethical?
So what is ethical and what is sort of a process is different, right? Or in my mind, right? So again, if different people will think, some people think about the ethics as very procedural, right? So they'll actually have a very concrete answer for you in terms of like, well, okay, is this person of age to be able to consent? Are they competent to be able to provide their own consent? And then if they're not, then there's like a list of people that you can then go to, right? So for the child, if the child is not of age, then you go to the parents. And if the parents don't agree, then you may call it an ethics consult. And like so there's a set of procedures. And for some people, the ethics is all about the procedures. Did we follow the rules? Did we follow the both sort of the regulatory and did we follow the rules? So that's one form of ethics. Another form of ethics is what's right and what's wrong, and that's a lot fuzzier, right? And a lot harder to to answer that question.
So we've been quiet today. It's that sort of like starting to hit midterms, dreary day kind of a phase that has everyone a little, so there are no wrong answers, but they might spark some interesting conversation.
I am curious about whether there will ever be clinically facilitated opportunities for siblings who have been marked as potential donors to hear from successfully transplanted sibling pairs, to have that kind of kid to kid conversation, or likewise like family to family.
Of course.
Is it?
Well, what about talking to kids where it didn't work?
Well, that No, that's true. Actually,
Sorry, I didn't mean that sounded very harsh, but it
no,
was
I'm
really
realizing that I
interesting.
said successful, but in my mind, as I was thinking about it for the last hour, I was envisioning both, like to actually have conversations of both sides or sibling pairs who were marked as like you're a match, but they chose not to as well. So they never found out.
Yeah, no, it's a great idea. And I think it goes into this also question of informed, like how does a patient become informed? There's the conversation that you have where you have to make a decision and you're speaking with an expert who knows everything there is to know around, the treatments and what the risks are of participating in a study and how those are going to interact. And they can talk about their own sort of experience and how that fits. But there's certainly other sources of information and of variable quality at the moment, right? So it's not always the best thing to be asking, the internet or ChatGPT. But you also sort of have this thirst for additional information, and people with experience is a good place to go. You just have to, again, like, is there access to those people, and are they presenting a fair, like, is that fair information or is it misinformation?
So I figured they'd go to YouTube.
Or go to
That would sound
YouTube.
what I would do. I would go to YouTube.
Yeah.
The answer is always Reddit.
Yeah.
Right.
That's what I'm saying.
I was wondering, since we're talking so much about like case scenarios, basically, in terms of, so you mentioned a sibling coming of age, that means 18 in this case, or can it, or is it younger?
Yeah, so I wanted to go back to Dr. Cohn's question that she posed. So we call that so when you're less than 18, and so basically 13 to 17, we call that process assent, meaning parents still give their consent, but 13 to 17-year-olds, and it's different at every institution what that lower age limit is. But that gap, if they truly understand, they can refuse to give assent. And so when you brought up, you have two teenagers, yes, we could have a 15-year-old say, I understand, and I'm not gonna do it. And I don't think it's happened to any consult, and I'm thinking of my colleagues, if we've had anyone who brought it to our meeting, that we've had a case like that. That we had to work through, but technically they can say no, and we'd have to go through the processes. And then the parent would have to make the decision and follow that ethical process and get the consult. But that's a really tough situation if, the teen who's 15 and the recipient who may be 16, they don't get along or whatever, and they say, I'm not doing it. They are basically declining assent.
Question or comment?
So I'm just wondering, you said in this case scenario, like if someone says flat out, no, I don't want to do it, you have to follow the process. What is the process? Like, is there a chance that they would be forced to do this even if they flat out say no?
So I think if we as a physician team and with the parents, like they're the parent, they want this for the other sibling and it's like the only donor available and there's no unrelated donors available, we could get an ethical so at the hospital there's an ethics team, and we could get a consult, get them involved and and go through that process. Like I said, thankfully I have not encountered that situation, but when Amy brought that up about what if you have two teens, and so she is right, when we have a 15-year-old and if they decline the assent, they don't have to, but generally that they have consented from the parents.
So you've got 1, 2, 3, 4, and then Julie and I know both have interesting questions, but remember, part of what we're trying to do is not just raise problems, but present solutions, right? So yes, you can be worried about the middle child who always gets asked to do everything. But maybe there are guardian ad litems that would represent that. So let's be thinking about solutions as well as our questions. Eve, then Kira, and then a row back.
In terms of, so following up on the question earlier, if a parent can give consent for a child that's like, does not have like, yes, they're sending basically consent, can the
doctor who's responsible for like picking a donor then reject that and basically say like, this is not the best option? Like two young children and then a parent says like, yes, the sibling can be a donor for the younger sibling. Can the doctor be like, this is not maybe the most ethical, or like, I'm uncomfortable with using this child as a donor for X reasons, X, Y, and Z?
So if that were to happen, thankfully, we had the National Marrow Donor Program. So I would go to my coordinator, say, do we have any other available 10 out of 10 donor? Look at the disease, look at the time in terms of how quickly we could get the donor and present the case to the ethical board, to the family. Here's our situation. Here's our risks of X, Y, and Z if we went with the unrelated donor versus the related. Thankfully, in the year 2023, unrelated donor transplants have gotten much safer and with outcomes nearly as good as related donors. So if that were to happen, we're in a better situation in 2023.
Yeah.
So yeah, coming from somebody, so my younger sister has cystic fibrosis. She has been evaluated she has not gotten transplant, but she's been evaluated for multiple. So I know we're talking about like the informed consent of like a teenager, but you can't really control for the fact that like the parents are almost certainly going to be pressuring
Yes.
a child that they have to do this. Like no matter what you do as the medical team, they're always most likely going to have that familial pressure on them as somebody who's been in situations where we've almost gotten to this point. So is there anything you think you can do from that aspect? Because I feel like that's one of those things that you really just can't control for, is that parental pressure on any children they have or are going to have to serve as a donor.
What we try to do for both the donor and the recipient, the donor undergoes their separate evaluation, but we just try and give as much facts and data. The data are the only thing that can really support the discussion. And thankfully, a lot of research has been done in this field, lots of data that have been published, and we can really share that with them now.
So we're gonna go, I'm sorry, I've forgotten your name.
Sarah, my question is very similar to, in line with what she asked, is kind of getting at parental coercion and how do you control for that? So.
Yeah, it's, I think just, especially when you're dealing with teens who can understand, just trying to speak with them. And this comes up because at a certain age, they have more ability to have assent and voice their opinion. I mean, even in non-cancer situation, I have a teenager, I can't go into her portal and just look at her things, it's her information. So they do have more rights, but as the physician, you want to share as unbiased, evidence-based information that you can to the patient as well as the family.
So I'm gonna take one from George, one from Christine, and then I want to shift us a little bit to a slightly different topic, and then we can come back to this if need be, but I want to make sure we get a chance. So George?
Yeah, for the cases like the ethical consultations, how well documented are they? And is there like access to them, or is there people that look at them to kind of think of how to move forward in like improving clarity of the situations?
Maybe Jody knows
I can
that.
try- So yeah, they're very well documented. I mean, they're a consult like they go into the medical record. And I know that our ethics consult team, they review them, they sort of do analysis of them afterwards to try to understand some of these bias questions and some of these other issues. I think that's very institution specific. I don't know if everybody does it in the same way, but it certainly happens. I just want to comment also on the last two, which are really interesting. Sort of what happens with sort of parental coercion. I think, when I was doing my ethics fellowship, most of the cases that came up were quite the opposite. It was what happens when the parent refuses the treatment on behalf of the child. And in that case, their competency as parents gets really sort of questioned. So I think, sort of to go the other way would throw the health system a bit of a, interesting set of questions, but anyway. I just wanted to mention that.
I just have a question about the informed consent process.
itself. I was just wondering if there's a possibility, or if they exist for educational materials where they break down the difficult concepts in the form. I know it's already discussed with the provider, but are there any efforts towards that where it's a resource that can be given to the patient after the conversation, before the conversation, or brought up during the conversation?
Yeah, so this is in some ways how she and I met, but there's also, like, I'm working on another project around informed consent for the use of newborn screening blood spots for research, and they're working on a video and, an app, and like there's other sort of, so yes, it's sort of like bubbling up in little like pockets here and there. But yeah, that's a great solution. I don't know if you have anything to add. Yeah.
That's okay. I was also wondering if, like, when those kind of materials are created, and then are they reviewed to just ensure that they're not coercive or
Yeah, IRB is very thorough in that respect.
So you did a perfect job of transitioning us where I wanted to go, which is I wanted to spend a little time, again, flying, we haven't had any flying monkeys yet, right? And we've got a few of you who haven't spoken yet, and I want to give you the opportunity. So we've talked about a bunch of problems. One is that the physician may be biasing, and biasing that sort of implies negative. So there's what I would consider to be a foundational problem of bias. If you have two patients who are clinically identical and you present different options or in different ways to them, then this is concerning. But there's also the two different providers might present the same information differently to a patient depending on their own preferences, values, experiences. What would I do for my family, right? We have the question of your level of education, English fluency, prior experience with clinicians. There are lots of places where this could go wrong. This issue of there's more than one person involved now, the issue of the age of the person. So one thing we talked about was, well, could we provide some educational materials that were presumably standardized across, maybe given before or after or during, so that people could have more options? But I'm going to throw up another idea, and then you get the third one, which is to think about maybe instead of it being a one-on-one conversation with your doctor who you have a long history with, maybe that consent process should be with somebody who is unbiased, impartial, whatever. Might be a terrible idea. And to be clear, we're expecting terrible ideas with the hope that one of them makes you go, huh. So I'm going to throw out that the relationship with the provider could add bias, because I really want this child to survive. I've been invested, and maybe I would want something different for my child. So a different person to consent, or to discuss the consent. Go ahead.
That was exactly what I wanted to ask, if social workers can be that person, like that third party, because if someone doesn't have a lot of trust in the health system, a social worker is not a physician or a doctor, so they might be more trustworthy, and especially that they've been with the patient for like some time. They can have some sort of personal relationship to advise them or to be with them during those times.
Go ahead. In
I'm
the back.
also wondering, the conversations about consent, are the children and parents separated for any of the conversations? Like, do you talk to a child who might be a donor one-on-one without their parents present? So you really get their feedback?
So it really depends on the age of the patient and their sort of attention level, but we try and keep everyone in the room. Donors get evaluated separately from the recipient. So even though they're siblings, they could be there because parent has to watch both kids. But in terms of the official donor evaluation, that's by a separate medical team. Yep.
Does it make a difference who you ask to consent first, whether it's the child or the parent? Or are you asking them to consent together, or you just ask after the fact? Does that make sense?
Yeah, it's generally together that because the parent is obviously bringing the child to the visit and it's been a while. I mean, we used to do donor evaluations together. It's usually a different doctor and not the primary doctor, but now it's by a whole separate team and not necessarily the BMT doctors. But it's still where the parent brings the child and they're talking about the donation process together.
So I'm gonna ask a slightly different, oh, go ahead and then I'll ask my question.
I had a follow-up about the questions and like the consent. Do you go for donor consent first or the recipient consent first? Because I'm thinking if the recipient really wants this, they want from their sibling, is that a form of coercion if that consent is given first?
It's all sort of happening in parallel. If we know that, we're only talking about a less common procedure, right? Sibling is only 25% chance match. And so it's usually happening in parallel where we're working up the recipient that they're fit enough to undergo the procedure along with the donor going through their separate. Usually if we are aware that there are going to be issues, then it could be a somewhat more disjointed process, but it's sort of, we learn from social worker and things like that. These processes are sort of all happening in parallel.
And for the consent to treatment, so I think I said it, like, if, you sort of give one-time consent and then it can be kind of hard to go back on it. And I think for the clinical treatment, like, it's voluntary all the way up until the very end, right? So if somebody's like, it's the day before everything's supposed to happen and they don't want to do it anymore, they can withdraw their consent, right?
Yes.
And then you won't
So
do
when
it.
you're an adult, that's absolutely the case. Now, when it's a child and the parent, like Jody brought up, if the parent refuses it, but the medical team feels this is what is necessary to save this child, then there are other legal, ethical, and we didn't even get into that type of scenario, more the donor, but that has come up and that is a whole separate discussion. But that can come up where the parent will say, I don't want this. But if the medical team feels this is appropriate and life-saving for the kid, because it's a kid, it is our responsibility as the healthcare system to advocate for the child.
Go ahead.
I have a question that's more on the later on process of this donation thing. So there's a chance that for all the surgeries they can be failed. So what if like the donor finally noticed that when he or she donates the thing, but finally the surgeries failed or become worse? Would that be some more ethical problems coming up later on, or would that be another like more on a security question that the donor shouldn't know who the person he is donating to, and then also who like both of them doesn't know each other?
They absolutely do not know each other, and we're not allowed that's what the job of the National Marrow Donor Program. They protect the identity of the donor. But after, and I don't know this, like X amount of years, if both parties give permission and they often want to meet the donor and the donor often wants to meet the recipient, through the NMDP, they can facilitate meetings. So we've had great reunions with people in Germany as a donor and the recipient. They can meet each other, but it's after a certain period of time. It's again informed consent by both people, but up until that process, no contact at all. The recipient, as you can imagine, wants to thank the donor. They can write letters, but it has to be through the transplant center to the NMDP, and they give it through that process. But they're not allowed to contact the patient until both parties have consented and after a certain period of time.
So what if this case is a sibling case? Like,
oh, so siblings, that's hard to keep anonymity. Yeah.
What are the ethics associated with discovering unexpected information.
This has come up, so.
Anybody wanna, so someone hasn't spoken, have a clue about what I mean?
They're not siblings, maybe.
Maybe the siblings aren't really siblings.
And so, when we do, I didn't get into the nitty gritty of everything. So when we do tissue typing of the kid, and the donor, we do the parents also. And so we learn information that the recipient, that may not be the father or the mother, that has come up. And it hasn't happened in so long that I don't want to speak incorrectly. It has not happened in so long, and I cannot recall what the latest recommendations are with that.
Judy, do you have thoughts about things that can come up during the act of consent? I know with blood donation, there's a lot of.
It's like when we find,
Variance, there's significance. Yeah, so there's, so there's also the issue of, maybe a disease, you're testing for something, but then it turns out you discover a gene for something else. Or if it's in the context of research where you're in study A and then 5 years later, study B discovers something that you may be interested in. So so this happened I'll give you an example, it'll be easier to understand what I'm saying, but the Havasupai tribe lives at the base of the Grand Canyon. And they participated, sort of agreed as a community to work with a set of researchers to understand diabetes in that community because it was high and they wanted help with it. They retained blood samples as a part of that study, and they participated, it was great. And then about, I don't know, maybe 5 years later or something, a graduate student from that community was at Arizona State University listening to a talk about the prevalence of schizophrenia among Native Americans in Arizona. And it turned out that was that same study, and that was not part of the original contract at all. Right. And so anyway, it didn't, anyway, for lots of reasons, it was problematic. So it happens, and it's something that we need to be very sort of careful about. And it's sort of, these things get embedded into an informed consent thing. It's like, we're going to collect this tissue and we'll use it for future research. And so going back to the community and saying, is this okay? Is this okay? Becomes really important.
So I know the recipient, the donor are completely blinded for a certain amount of time. Can the recipient contact or be in communication with other previous recipients or potential recipients? Because I'm currently doing interviews with cancer patients, and the first thing they look for when they get diagnosed is a community of patients who have similar in the same situation. Is there potential for having them to talk to another patient who have either already received bone marrow transplant or has consented already or did not consent alternatively?
Yeah. So you brought that up as coercion. So it never even crossed my mind, but you are absolutely right. And we do get asked all the time by families, oh, can I speak with someone who's been through it? And so we generally say yes, but we need to get their consent. And there's a process that we have to get their permission, and we will often have that individual contact the patient if the patient says it's okay to give my information for them to contact me. But you are right. It can be, you have to think about that in what context you're doing that for.
I think it's where it's coming from, right? So if you as a physician are like, oh, I have this patient who I know is going to tell you it's the greatest thing ever.
Yeah.
And I'm not going to send you to the patient who, as an adult, is fighting with their sibling and, understanding. And I think that kind of comes back to some of the educational materials and whatnot is that consistency of, here's a case study where it went really well. And the siblings were very close and it was a low risk procedure or whatever. And here's a case where it went poorly and the sibling who was the donor felt guilty even though it wasn't their fault, right? And be aware of that. Or here's a case where, you know, I always worry about, like, I find out who I donated to, and it turns out they're a really bad person, right? Like, I donated to the person who then became an act. So it seems like kind of recognizing that it's not just clinically what happens to you,
Yeah.
but that different people are going to have different things that they care about
Yeah.
down the road, and not choosing for them which story that they need to hear, but having sort of, yeah. Okay, so we have a few of you who haven't had a chance to contribute, and we're really close to at time. So I'm going to give you the opportunity for parting comments or questions before we wrap up. Cool.
I have a question regarding like accessibility, what constitutes being informed. You said like some like for clinical trial and everything else, maybe a consent form is like 150 pages, which would you say?
So one form might be 15. yeah,
Okay.
maybe 10.
Okay.
So not one form is 150
Okay.
pages.
Yeah. That's better. But are there like metrics or guidelines in place that like allow you to judge like what is an appropriate amount of information to give someone? Because I feel like if you give someone a lot of information, yes, they'll be really informed, but also is it like fair to present that to someone who maybe English isn't their first language, or they're not well educated, so they're not able to understand all the information, but also like on the other hand, if you dumb it down or reduce the information too much, like simplify it, maybe they're not fully informed.
What we've found, so some of the work we've done is trying to understand, like, so again, about around sort of just where is your health information and how is it being used? And asking people, you know, so people want to be notified, period, whether it's, you know, a complicated procedure or something, you know, about just health information being shared or not. People want to know. And how they want to know is going to be really different. So there's also like how much information, what is the delivery mechanism? And I think the answer is ideally you do all of the above. So you put the information in the patient portal when they have time to read it. You go over it with your doctor or the researcher at the time of enrollment and sort of get your questions answered then. You get reminded every once in a while, oh, remember you were in this clinical trial. Here are some things that we learned and you contributed to science and the discovery of new treatments. So it's sort of an ideal world. It's all of the above. And then convincing health systems and people to invest in it is the other thing.
That's a great place to end. Thank you both so much. As you have other ideas, I think this is very different than some of our other topics in the sense that there's so many
Moving parts.
yes. But thinking about, you know, there's technology that helps us communicate information better. There are mechanisms that help us to establish privacy. So pass along your ideas as you have them. And thank you both so much for spending the time with us.
Questions. Yeah.